Well, good evening, everybody, and welcome to our event tonight, Sleep and Settling from Newborns to Tweens. Thank you all for coming. Before we start, I'd just like to do an acknowledgement of country. So the Northwestern Melbourne Primary Health Network would like to acknowledge the people of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. Just a bit of housekeeping before we start. If everyone could just keep their microphones on mute for this session. If you'd like to ask a question, if you could please do it via the chat box. We'll do a question and answer session at the end of each presentation. So there's 2 presentations tonight, and your questions will be anonymous to protect your privacy. And just to let you know, this session is being recorded. And please ensure that you've put your name correct into the Zoom meeting so that we can keep tabs of who's attended tonight. Just to let you know of upcoming education and training sessions that we've got that are being delivered by the Primary Health Network. Next week, we have a how to run a scalable, profitable and sustainable mass vaccination clinic without losing your sanity. I think there's probably quite a big demand for that session. So that's on next 4th of August, I think that's next Thursday. We've also got ovarian cancer screening and updates on colposcopy referral criteria by the Royal Children's Hospital. Medicines in the last days of life, which is another session on the 19th of August. And improving complex dyspnea, a collaborative pathway, which is on the 31st of August. You can always look on our events section on our website, which is detailed there. Health pathways. For those of you who, a lot of you will be using health pathways, a number of you may not be using it, but might want to use it. So it's a free service that's provided by the Primary Health Network. It's a collaboration of all the evidence-based best practice, all the clinical guidelines, all the pathways for practically all the conditions you can think of, all in one place. So it really saves a lot of time. So it's a fantastic resource. It's free for you to use. It's continually being updated. So if you'd like to use it, just get in touch with the Primary Health Network and we can arrange access for you. So the speakers tonight then, first of all, we've got Professor Cathy McMahon. She's the Clinical Director of the Werribee Mercy Hospital. So Professor McMahon is the Clinical Director of Paediatrics and Special Care Nursery at Werribee Mercy. And Cathy is also the Chairperson of the Director of Paediatric Group for Victoria and is heavily involved with Safe Care, being the Chairperson of the Insight Group on the Paediatric Expert Working Group for COVID and a member of the Paediatric Governance Group for the Paediatric Clinical Network. Second speaker, we have Dr. Rachel Madwin, who's a paediatrician also at the Werribee Mercy Hospital. So Dr. Madwin is a paediatrician who works primarily in Melbourne's West with a focus on providing comprehensive and accessible specialist care to children of all ages from birth to adolescence. She's a consultant paediatrician at Werribee Mercy Hospital and St Vincent's Private Hospital. And Rachel also runs a busy private practice in 2 locations across Werribee and Williamstown. So I'll hand you over now to Professor McMahon to start with.
Thanks, Catherine, and thanks for coming along today. I was just saying before that with COVID, our restrictions coming down, I thought everyone would be out on the town, well, out at the restaurants. So, and look, I'm happy to take any questions along the way, so please speak up. And I'm just going to share my, I'm going to share my screen in a second. I'll stop yours, and can you let me know, Catherine, if I'm when I'll put it in presenter. Right, and I will. Right, can you see that as a?
Yes, it just needs to be in your presenter mode.
It's not in presenter mode? Right.
No, that's it. Yeah, good.
It's fine?
All good.
All good.
Yeah.
Okay, so I think, you know, being a paediatrician, you often go to clinic and you've got a baby coming in, and without fail, I reckon 50% of them will say, look, you know, they've come in for a result of an ultrasound or a weight review or something pretty menial, and you'll think, oh, this will be a quick one. And they've always got, you know, issues about sleep, unsettling. And so I think, you know, we all need to know about it because it's such a common problem and nobody gets taught much about it. Before I had kids, I was the first registrar on the sleep clinic at the Children's Hospital, and it was one of the best rotations I've ever done, most practical paediatrics, and it was a fantastic rotation. I spent a year as the paed reg on that when I was a fellow there, and it was a fabulous learning thing, especially when I had kids. So my talk is about the earlier times, the under 6 months, the stop the crying, but also what's normal in sleep. So I'll just... So first one is just a common scenario that happens. 4-week-old comes in, not sleeping much. So they've come in for another problem, but they've come to you and they've said, look, you know, doc, I'm not sleeping much. They're not sleeping much. They're sleeping on mum or being fed to sleep. The parents are exhausted. What do you do? So what advice can you give? So I think this is quite a common thing. They say, you know, another concern I've got is they're not sleeping. Well, the first thing I always ask is, do they want help? Do they want advice? If parents are happy with how things are going, that's fine. You're not to, you know, we're not here, you know, to appraise their sleep things. If they're happy, everyone does things differently. And if they're happy, I say that's fine. But if they want help, there is some help that we can give them, and there is guidance that we can give them. So I'm just going to talk also about what's normal sleep and what's unsettledness, because although babies, the ideal baby is meant to sleep, you know, 23 hours or 22 hours a day, 20 to 22 hours a day, and not being unsettled, but that's in the movies usually. Some babies do that, and then some babies don't. And some strategies that can help, I'll talk about that. So first up, do they want help? And as I said, it's really important to find out what they want. It shouldn't be your agenda. And I've got ideas about how I think people should parent kids, but you know, you shouldn't be telling others how to do it. Everyone, and if they're happy with how things go, you leave it. But if they want help and they're looking for help and they're exhausted, that's when we help. So how much sleep should babies have? And this is a little table from Harriet Hiscock. Harriet Hiscock is at the Children's Hospital, and Harriet's a fabulous, she did a PhD in sleep, and especially the association with maternal depression. And we do know that mums get depressed if their babies aren't sleeping. But as you can see, newborns, they sleep between 16 to 18 hours sleep in a 24-hour period. And each sleep should last 2 to 4 hours. By 2 to 6 months, they usually have 2 to 3 sleeps for up to 2 hours each day. And some babies do just catnap for one sleep cycle. And they commonly still wake up once or more during the night. By 7 to 12 months, day sleeps are 2 to 3 hours in total, usually as a morning sleep and an afternoon sleep. And then a night sleep usually goes from about, between 6 and 10 p.m. until 5 a.m. or later. One nighttime feed is quite common, but some babies by 8 months, 60 to 70% of infants don't need to be don't need to be fed during the night and are able to settle themselves back to sleep. Toddlers, 12 months to 3 years, and Rachel will talk about this, there's 20 to 13 hours sleep in a 24-hour period, and at around 12 months, night waking may increase due to separation anxiety, which peaks at about 18 to 24 months. At around 18 months, naps are likely to decrease from 2 naps to 1 and are taken at a time that best suits the child. And then when they're preschoolers, when they're at kinder, 11 to 12 hours sleep in a 24-hour period, day nap decreases from 1 to none. And that's roughly, kids all do it differently, but that's a rough guide. And we'll give you, look, I'm happy for you all to have a copy of these slides afterwards. So I think this is one of the things that I've always liked, how your baby sleeps and infant baby sleep cycles. And as you can see, babies go into deep sleep, light sleep, awake, light sleep, deep sleep, then up to light sleep, then down to deep sleep, then up to light sleep, they wake momentarily and then they go back down, and they cycle through this. And I think this is one of the things I've learned over the time, is that how you get them to sleep during that awake time is how they expect to be resettled when they do have those momentarily awake times during the night. And I always liken this to, we know, we often wake up during the night. I know I do. It's dark. It's not light. You roll over and go back to sleep. And that's what we need to teach the babies. And there's some sleep associations that occur during that wake, which will make them wake up. So if you're rocking your baby to sleep every time, when they go through these light sleep and awake, they may want to be rocked again. And so these sleep associations are really important early on if people want to help with their sleep. So strategies for settling babies. Babies do have, initially babies often just feed and sleep, but then they have some wake up times, they have some awakening times, and it's really important to look out for those tired signs. And that's often babies becoming irritable, babies yawning, babies becoming unsettled. That's often babies knowing that they're becoming tired. You need to have a proper sleep environment, and that is often in a room, the same environment, in a darkened room with minimal stimulation. And, and with that sleep, when they come into the wake and then wake up and they can resettle, it's important to try to put babies into the cot or bassinet awake. Therefore, they can learn to self-soothe and go back to sleep again by themselves. And that's important to learn from very early up. And what we teach people, and especially at some of the settling clinics and sleep clinics, you learn that you put them into the cot and bassinet away. If they become upset, you're there, you stroke them, you pat them to try to settle them. And once they're quiet, you move away so they can self-soothe and go to sleep. Sleep associations, and I was talking during that awake time, sleep associations are very important. So it's important putting them into their cot, into their bassinet, awake but sleepy and tired. And if you have parent-dependent sleep associations, which are things like rocking them to sleep, feeding them to sleep, walking in a pram to sleep, driving around the block in a car, babies will often want that when they go into that light sleep, and that can occur every 20 minutes. And it does go out to about an hour or so later on. But babies will wake up, they'll say, "I'm not being rocked to sleep," and they'll cry out until they're rocked to sleep again. So that's important that we try to teach parents about what are parent-dependent and then what are parent-independent sleep associations. And that's such as a dark, quiet room, a same sleep pace, so they know, yep, this is time for sleep. Swaddling. And swaddling means, you know, early up in the first couple of months, you can swaddle babies, wrap them tightly. Important that their hips aren't wrapped in tightly, but wrap them tightly around their arms so that they're not hitting themselves in the face to wake up. And then patting and stroking until they're drowsy but not asleep. So you can, parents can learn to pat and stroke, but as soon as they're quiet and settling down, you're out of that room, trying to get them to do so that when they go through that light sleep, they don't need you there again. And they're really important things to learn very early up. So this book is a guide for parents, and I actually bought this book because I think it's great for parents, and I give it, and I actually, every clinic I have, I reckon I give out 1 or 2 of these to parents. And it's by Harriet Hiscock, and it's about baby business and sleeping and crying in the first few months. And it's a really good resource about what's normal, what are some strategies to help. And so you can go online and purchase that, and you can actually print it out for families. But I find it a really good resource because there's, because parents don't often know where to go for help. There's also Raising Children. I don't know if you use Raising Children Network, but that is a fantastic evidence-based site. The Children's Hospital have had a lot to do with it. Frank Oberclade, who's an old boss of mine, he used to be head of community child health. Frank has been instrumental in starting this up, and it's a fantastic. They've got videos, they've got leaflets, they've got lots of stuff from birth right up to adolescence, and it's a fantastic site for parents and professionals to look at. And so I've got here, and hopefully this will work and you'll be able to hear. I've got one of their little videos. It's just a couple of minutes, and I thought I'd play it because it sort of says to you, this is what you can say to parents about sleep and settling. So hopefully you can hear. It's very quiet.
When your baby is crying, it can be hard to keep a level head, but it can help to go through a checklist of all the things it might be. 1, does she need your comfort or attention? Try holding her in a cradle position, gently rocking, walking with her, quiet whispering, or singing. 2, is she hungry? Follow your instincts, but if she has fed in the last 2 hours, you might try something else to help her settle. 3, does she have a dirty nappy or a rash? For rashes, rinse with clean water, pat dry, and use a barrier cream. 4, does she need a burp? Try holding upright and patting her back, which can soothe her even if she doesn't need to burp. 5, is she uncomfortable? Check that she's not too hot or cold and has comfortable loose clothing. 6, does she want to suck? Offer her a dummy or help her find her own fingers to suck. 7, is she overtired? If she's been awake for a while, try wrapping her gently but firmly and putting her down in a quiet, dark and safe place. 8, are the conditions right for her to settle? Try reducing stimulation by making the room darker and quieter. A gentle, regular sound of either soft music or white noise from a fan or radio between channels can also help her tune out. 9, is she sick? Does she have a fever? Take her temperature. Talk to your doctor if you have any doubts. 10, do you need a break? Give your baby to someone else. If you're on your own, put your baby down in a safe place and take a break. Try again a few minutes later when you are calmer.
Baby's not going to hurt itself from crying too much for an extra minute. That minute that you just spend away from the baby, it just gives you time to think and come back when you're a little bit more relaxed.
So I think, that's just a nice little thing to go through. But I think that important thing at the end is give yourself a break. And some parents are at their wits' end with a baby that's unsettled and not sleeping. And I think it's important to give them permission to, go outside, go for a walk just around the house or around the block and come back and see that the baby's okay, because babies won't hurt themselves. And it's important that parents are looked after, because it can be a really trying time. So next we're going to go through a case of a 6-week-old. unsettled, worse in afternoon. Parents come in and say, is this colic? And this can be a really trying time for parents. And all these so-called, they're all the relatives who are such experts on these areas, which they can be helped, but they can be a great hindrance sometimes. So what is colic? There was this guy called Wessel in 1954. He was the fellow who first started saying there was paroxysmal fussing in infancy, sometimes called colic, and they diagnosed it. It used to be the rule of 3, and it was more than 3 hours a day, 3 days per week, and for 3 weeks. And that was the initial definition that we used to use. But another definition is what is colic, and colic is a self-limited and benign functional disorder of paroxysmal, uncontrollable crying and fussiness in otherwise, and I think it's really important, healthy infants less than 3 months old without an obvious cause. And I think that's important because I'll talk about what else it can be. And we still don't know exactly what colic is, but we know it's a developmental phase that many babies go through. And I don't know if any of you know about purple crying websites. There's a purple crying website, purplecrying.info, and the curves of early infant crying. And as you can see, at about 2 months, 6 weeks, the high criers can cry for 5 to 6 hours per day. Can you imagine that? Whereas the low criers will cry 20 to 30 minutes per day. And so I think, it's really, as you can see, from 2 weeks, it increases to maximise in about 2 months. And usually it's improved dramatically by 4 to 5 months. But as you can see, there's a great variation in the amount of crying some babies do. And the letters in purple stand for P is for peak of crying, unexpected crying, resist soothing. And I think this is really important because people come in and say, but they're in pain. But pain-like face, a crying baby may look like they're in pain even when they are not. It's long-lasting and it often appears in the evening. It's often in the evening. So that's what, purple period of crying is what we call colic. The important thing that it does resolve in 86% by 3 months. But what are the red flags? And what are the things when parents come to you with these concerns? What are the red flags? 5%, about 1 in 20, have an underlying medical problem. And this was from a study done in 2009. And I think the thing is, I always get concerned about the new onset of crying, fever, any lethargy, or any other symptoms or signs that appear. I worry, is there some other reason for it? So kids presenting or babies presenting, parents presenting with children to emergency department and with unsettled babies, we know that 5% that present to ED in this study done also in 2009 had urine infections. And I think it's always important, get a urine, it's always important to exclude that, but 5% had. The other causes varied greatly, but other causes were raised intracranial pressure. A child had a non-accidental injury. So non-accidental injury, inguinal hernias, always do a good examination of them. Hair tourniquets around their fingers or toes can cause it. But it's really important if parents come to you with unsettled babies, and especially if it's a new onset, it doesn't fit the, doesn't fit the criteria exactly. Think about, is there another cause? And it's really important. I've seen some funny causes of unsettled babies. I've seen, babies with meningitis. I've seen babies with SVT that have come in unsettled. As I said to one of the medical students today, I said, paediatrics, babies and children can't talk and say, I've got a pain in my chest. my heart rate is racing, I've got palpitations. They can't say that. So we need to find out about that. So the other thing is cow's milk allergy is a big thing, and swapping formulas happens all the time. But what is the basis for this? So David Hill was one of the first allergists at the Children's, and when I was there as a junior doctor, he was an old bloke then, so he's really old now. So could this be a cow's milk allergy? And this is looking at crying at baseline compared to being on a low allergen diet, cow's milk free, compared to a control diet. And there was a significant difference in some of them put on a low allergen diet or cow's milk free. And he did say there is some suggestion that some of this could be due to cow's milk allergy. But when should you consider it? And I think when there's feeding issues, when there's vomiting, when there's especially diarrhea, proctocolitis, they can get bloody diarrhea, when there's poor weight gain, when there's widespread. And I always say eczema is unlikely to be due to food, except when there's widespread eczema in babies and the red disposition, that is often due to cow's milk protein issues. And that's when you should consider it. So dietary modifications, well, obviously for a breastfed mum, it's staying off cow's milk and usually soya milk. But if they're formula fed, these are the ones you can consider. Now, we usually don't consider soya-based infant formulas for less than 6 months as a rule. My dietitian friends don't like that, but extensively hydrolyzed formula, as a GP, you can get over-the-counter ones. Aptamil, Alapro, can be over the counter, so you can actually suggest to parents they go on a 2-week trial of that to see if that improves it. There's also the PBS ones that we can prescribe, Alfare and Pepti Junior. Then there's also that you can also get a rice protein-based formula, which is non-cow's milk and non-soya milk, Novalac allergy. And that's over the counter. So I think Novalac and Aptamil Alapro are the ones that you could suggest if they have other features. They've got feeding issues, they've got vomiting, diarrhea, they've got widespread eczema. And I just had one in clinic last week, widespread eczema, vomiting, unsettled. She's gone on a Pepti Junior. There's also the amino acid formulas, which are also PBS, but I think these two are the ones you should be thinking about. Probiotics, that got a big rap in the press a couple of years ago because there was a PhD, Valerie Sung, I think it was, who did it at the Children's. And really, when you looked at the data, there wasn't a lot of difference, but it was a mild difference in breastfed infants, only breastfed infants under 3 months. It was this Lactobacillus reuteri, and it was those with excessive crying, 5 drops a day for 21 days. And it wasn't for formula-fed babies. It was only seen a slight difference in breastfed infants. But really, when you looked at her data, it wasn't a great difference. But the Cochrane has done a review since then, and Cochrane has said, they felt there was insufficient evidence to suggest probiotics. So what about other treatments? Anti-reflux medications, there has been a big push against that, and we know that babies have side effects from them. It can affect their immunity and their bones, so there is no such thing as a silent reflux these days, and it is really, Safer Care have been involved in a project with trying to stop people prescribing anti-reflux medications unless they've got significant vomiting. We're not meant to say that kids who've got any dyspepsia unless they're really vomiting a lot. Anticholinergic medications, colic mixtures like Brightwater, Infacol, Degas infant drops, no evidence of any of these having any difference. Look, sometimes I say, I just say, okay, whatever, but there can be side effects with some of these. So I think it's really important. So what do you do? really important to support these parents, and especially the mothers who may be at home with this crying, unsettled child. I think, you know, the health pathways, they actually have some fantastic resources. And Scott Parsons has worked with Harriet Hiscock, who I think is the guru of sleep and unsettled. And they've got some really good pathways about the unsettled and sleep in babies. But I think what these are, you know, godsends, you know, the sleep and settling clinics. And there's the public hospitals who have day stays and extended stays for parents who are really struggling. The Mercy Health run the O'Connell Family Centre, the Queen Elizabeth, there's the Queen Elizabeth Centre at Noble Park and Tweedle, which is our local one. And I'm not sure if you know that the government is putting another one out in Werribee. You know, there's some design things happening at the moment. So there's a whole lot of new sleep and settling clinics being developed in Victoria. There's also the private hospitals do have them for people who've got private health, and that's Masada, Mitcham, North Park and Waverley Private Hospital have early, and they're fantastic, and people often come out of there a new person. So I think when people are really struggling and can't do it themselves, they should think about that. But it's really important to support people. So do these programs work? There is evidence that it improves sleep, it decreases crying, it decreases postnatal depression. And the concern is if we don't help these parents, you know, in a big study in 2004 in the Netherlands of unsettled babies, 5.6% had had physical abuse. And, you know, it's very trying having an unsettled baby, but if we don't support these parents, this can happen. So just letting you know that the Children's Hospital have an online course on understanding children's sleep from birth to 5 years, and that's on the 8th of September and 15th of September. There's two 2-hour Zoom sessions that you can register for, and I think it's a great thing to do. I think it's a great resource to have and understand. And just my last slide is, you know, Baby Talk 101, wah. And this is a good one. It means until my every need is met, your life will be hell. And I think, you know, just remember that babies they only know how to cry, you know, until they start smiling. So thank you very much. And I'm happy to take any questions. Thank you.
Thank you, Kathy. That was fantastic. Some really useful tips and tricks there, and also some fantastic resources, and even some courses for further training. If anyone's got any questions, please put them in the chat. I've just got one for you, actually, Kathy. What's your opinion on the use of dummies? I know it's gone in and out of fashion over the years for settling children. Is there...
Like, I used to be really anti-dummies, and that's because I used to see babies, older babies, in the sleep and the settling, the sleep clinic at the children's, who'd the dummy had fallen out, and then they couldn't find it, and then parents had to get up to put them back in. But it's actually, you know, we know that SIDS, you know, there's slight evidence that, you know, dummies are good for SIDS, and dummies are good for soothing. And I'm whatever people like, but you have to realise that it's better if babies can find their own thumb rather than, you know, than a dummy, because they can find it in the middle of the night, especially as they get older. And I'm happy people having them, but, you know, yeah.
Great, thank you. Look, if people think of any questions, please put them in the chat and we can ask Kathy at the end of this session. But I'd like to hand over to Rachel.
Hello, everybody. Thank you for joining us. Just see if I can share this. Is that coming? Where did you go? Sorry, it's just shrunk away on me for a minute. Apologies, I'm just trying to get it back to a size that I can see. When I tapped it, it went small.
You just need to tap on the presenter mode. which is the...
I can't actually see that at the moment.
Should be at the bottom of the screen.
Yes, I don't have.
If you run your mouse.
I'm sorry.
Got it? No. Look, we can still see it.
I can't.
If you double.
Just give me 1 second.
Yeah, you can see it.
No, it's just gone. It's just shrunk down really small for me.
Okay. Look.
Do you want to open it up again, Rachel? Just see.
I might have to open my whole Zoom. That's all. Just give me 1 second. It's all there. It's just. Wait, give me back the screen mode.
Has Claire got the slides that she could put them on?
Yes, Claire's got the slides.
I've shared it though. It's just my screen shrunk away. I'm sorry. I'm not sure what happened and how to get it back. I can see myself.
Yeah.
There we go. We're back.
I think Claire's showing the slides now. Yeah.
Okay.
Yep.
Am I going to be able to move them through still?
So if you click on that one, that's it. Slideshow. Yep, perfect.
Now, sorry about that, everyone. So today I was just going to go through an overview, I guess, of the more common behavioural sleep problems, and hopefully give you a framework as how to approach them, because there are a lot to consider. So I'll just move through that. So they're just the objectives there, just looking at the different sleep problems. And then going on to the big question, that doctor, my child can't sleep or won't sleep, more importantly, can you help me? So the answer really is yes. So I'm not able to move the slides.
Yeah.
So essentially sleep problems affect 20 to 30% of people. They can cause a lot of stress and sleeplessness for parents, as we know, and can lead to lots of behavioural challenges and difficulties for the child. One study showed that, just the next. I think Claire might be controlling my slides, so just going back, sorry, which makes it a little bit more difficult. So the primary care physician can support this just with some behavioural interventions within less than 3 weeks. But if you leave it, it can lead to complications for up to 3 years. Just the next one there. So I know Kathy already went through the normal sleep, but it's really important in understanding sleep problems in children. As Kathy was talking about, children cycle through deep sleep and light sleep, and importantly for sleep disorders is their non-REM and REM stages. And so as children become older, they start with more REM sleep than adults. They have deep sleep for the first few hours. They start with shorter sleep cycles as babies, and then this increases. And then by 3 months, they're starting to establish their sleep cycle. So we see different types of behavioural sleep disorders emerging as these sleep cycles change and as their REM and non-REM sleep also changes. So for example, in the earlier night with increased non-REM sleep, you have more arousal disorders, and then with your REM, you start to get the more nightmares. Just the next one again, please. As Kathy touched on, as you get older, you need less sleep. So we don't need to go through that one again. So an approach to sleep problems. So getting a very detailed sleep history is really important. So considering a number of trigger questions can help to sort of find a pathway as to where to start. For example, at what age did the problem begin? What else might have been happening at that time? And how much of a problem is this for the family? What other factors are associated with it? And who's most affected? and it can be important to find out what they've already been told about the problem, and also what their expectations are, and culturally what the sleep practices are. Just the next one. And it can also be helpful to use an algorithm based on age. Next slide. I won't go through all of this, but this is just more details about the importance of getting a very precise sleep history. So looking at temporal associations, so with napping, daytime sleeping, and using a structured diary for this can be helpful. Looking at detail at things like night terrors, exactly the time they're occurring, because this can help with the management. Asking questions about obstructive sleep type symptoms, family history, general medical developmental problems, as there are a lot of sleep problems associated with developmental conditions, and anything that's happening in the family at the time. The BEHS algorithm is quite an easy and a nice way to approach a sleep history. So looking at your bedtime problems, excessive daytime sleepiness, awakenings during the night, your duration of sleep and snoring. And there's some sort of tricky questions here you could ask at different ages. For example, 2 to 5, does your child have problems going to sleep? 6 to 12, are there any problems at bedtime? And then you can also use this for 13 to 18-year-olds, where you direct the questions directly to the child. So that's just a nice reference there to make sure you're covering all of the possible sleep problems. So this is an example of a sleep diary, and I often give this to parents to fill in for children of all ages, as it helps them to also think about what's happening, and so you can try and find out whether there is a pattern. So they just fill in when the child is going to sleep, when they're waking, and what interventions might be in place at those times. And having a good 24-hour pattern is helpful. So this is just an overview of the broad range of sleep disorders there are. Obviously, we're not going to go through all of these today. We'll just focus on some of the behavioural sleep problems, the circadian rhythm problems, and if we get a chance towards the end, we'll have a look at some of the obstructive sleep type problems as well. So first of all, a case. So a mother calls you because her 2-year-old daughter does not want to go to sleep at night. When she's placed in a crib, she prefers to play and does not fall asleep for 1 to 2 hours. So what is your approach? What would your diagnosis and management be? So we'll work through this and come to a plan at the end. This is a big overview. So obviously I don't expect you to remember or go through all of this, but we'll just work through some of these problems. It separates it into 2 different categories in a system that I found quite helpful for trying to recognise the different sleep problems with age. So if we look at the difficulties falling asleep, arousals once asleep, and then excessive daytime sleepiness, and then we can break them into ages. So first of all, we'll just briefly look at the infant. We won't go into that too much because that's already been looked at. So just the next one. So the infant will have difficulties falling asleep. All of them will have a sleep association at all ages, and the circadian rhythm disorders, which I'll go into. So if you just can keep moving through the slides for me. And the next one now. So for the infant, Kathy's covered a lot of this already, so as I said, I won't go in detail, but sleep association is a big problem. So under 2 months, but for all ages. And so for the younger children, it can be parent dependent, so needing to have the parent with them, or independent like the dummy, as you've talked about. The management is basically to place them in the bed alone and awake for their naps and bedtime. Babies get hungry. So most babies still need to be fed until 6 months, as they might just be waking because they're hungry. And the next one. And then they may start to develop a circadian rhythm disorder. So basically they're just not tired. So they need to have less naps during the day. For preschools, falling asleep, again, you've got your sleep associations, and then you start to get more of these circadian rhythm disorders. Again, not tired. So they're having a late nap, so they just don't want to go to bed. And so the management is to put them to bed when they're tired, and then advance, which means make their sleep time earlier, slowly by 15 minutes, and keep them the wake up time the same. Just try and just reset that circadian rhythm for them. Around this age, we see a lot of limit setting problems, and so that's often due to lack of routine, no naps or poor naps, and just not enforcing the plan at home. So to manage this, it's about setting the routine, enforcing the one more time when the child gets up again, saying that this is the last time. Sometimes you can use a ticket system. So for these children, if they have a ticket where they can come out of their room one time and they can get a reward for that, that can be helpful. And then also around school age, you start to develop bedtime fears. And so this is easy just to try and identify and resolve the worries. When you move into adolescence, again, the circadian rhythm disorders become more of a problem. They're just not tired. And again, with no limit setting. When you're getting older, the best way to actually improve a circadian rhythm disorder is to make the sleep later by an hour each day and advance it around the clock. I've not had many adolescents successfully do this, only 1 or 2, because it takes a lot of dedication. So for example, if they go to bed at 10 one night, the next night they need to go to bed at 11, then 12, then 1, all the way through to the morning. And said that's a big commitment to be able to do that. So most will advance or sleep earlier by 15 minutes per night and then gradually go backwards. And often we'll use some melatonin to help them achieve this. School-age children also start to develop a lot of anxiety around bedtime, so trying to identify these stresses can help. So next we've got the arousals once asleep. So we looked at our difficulties falling asleep, and then the arousals, so the awakenings once children are asleep. And anyone with children will know that these can happen very frequently. So if we can move just to the next one again. In infancy, I won't go through all of these because we've touched on them, but there are many reasons for babies to wake up. One of the common ones we see is this 8-month, what the parents always come and present you as 8 months regression, which is to some degree true. But around this time, babies do develop a fear of separation, so tend to wake up more often. And the best approach is to allow them to self-settle and not to go and start to give them attention. And they might also develop an early phase shift. When you're getting into the preschool age, again, you've got your sleep associations, but now you're starting to get your nightmares. And as I mentioned earlier, when this happens later in the night with your REM sleep, and the nightmares can be differentiated from your night terrors because, one, they're later, and second, the children are frightened. They do wake up and they can remember it. And the best way to approach is to look at their daytime stresses and address them. Then you get all of your other disorders of arousal, which occur within 1 to 1.5 hours of going to sleep in your non-REM sleep. So these are your confusional arousals, which are often in the younger children, sleep terrors and sleepwalking. So I don't know if anyone's seen a sleep terror, but children will just scream uncontrollably at times and not be able to be consoled. And so this is often very concerning for the parents that there's something terribly wrong with their child. Sorry, just going back 1 step there, if that's okay. With the sleep arousals, the best management is to reassure that they're benign and they won't cause any problems. You can try some scheduled waking before you know they're going to occur, and increasing sleep is the best way to prevent them, and also safeguarding the house for the sleepwalkers. Next one. Again, with the preschool, there's the curtain calls. So these happen very early. The kids haven't gone off to sleep. They're happy, defiant kids. They just constantly find a reason to get out of bed. And so the best approach to this is just constantly returning them to the bed without much interaction. And then we've got other things like restless leg syndrome and obstructive sleep apnea. And then with adolescents, the main thing to point out with adolescents is that now we're starting to get other problems such as mood disorders that need to be considered and addressed. This is just the parasomnias, just going back here, just an overview again to remind you that the night terrors will occur in the early night during the non-REM, the nightmares in the later night during the REM, but also not to forget about epilepsy, which can also occur. And then we've got your excess daytime sleepiness. And so this tends to occur, you can go to the next one, thanks. just due to not enough sleep. So when you have sleep debt or deficit, it tends to occur in the older kids when they're starting to control their sleep schedule. So they're just not going to bed. And so having shorter periods of sleep. Also see it with obstructive sleep apnea and narcolepsy. So the general principles of management, we need to look at bedtime routine, which Kathy's also touched on for the babies, having a good sleep schedule. Sorry, just going back. Addressing the sleep environment, so making sure it's calm, dark, and non-distracting, and then really important, limit setting. There are some targeted interventions which you may have heard of or may even recommend. So one of these is extinction, which is just ignoring the behaviours. And so this is hard. So that basically that's just leaving the child when they're upset or awake and not just letting them to settle by themselves. The second is a graduated extinction, which you might know for smaller children, like controlled comforting, where you would leave the child, return maybe after a set period of time, which might be 2 minutes as an example, and then gradually extend that time until the baby or the child falls asleep. The scheduled awakenings, which we talked about for things like some of the parasomnias, and then the next one, camping out. This is often helpful for more anxious children. So the parents in this case will go and sit with, for example, sit beside the bed with the child and then gradually move out of the room overnight. So the second night they might sit near the bed and then gradually move their chair out of the room. If the child wakes during the night, they would then go back to where they were sitting. It's a longer process, but it tends, for the children who are more anxious, it tends to work a little bit better. And there's a complex process of bedtime fading, which I won't go into. It takes a lot longer. So one of the concerns of parents is, do these strategies cause harm? So if they leave their child, especially the younger children, to scream, will it cause them long-term problems? And there were some studies performed that found here for 400 children that it did not cause any problems. So it reduced symptoms of maternal depression and had no impact at all on child behaviour, parent-child relationship or parenting style 2 or 5 years on. So they're actually quite safe to do. And so reassuring the parents that it's actually okay to do this can be helpful. I just wanted to talk a little bit about co-sleeping because it's very common and it's often the default. So it's a norm for most cultures. Some studies do report improved sleep for mothers who co-sleep, but typically it's the parents who get affected by the co-sleeping. There have been some studies that show increased arousals and awakening in the infants who sleep with their mothers, so it's actually not better. They're woken by their mothers. And the next one. And often families will resort to co-sleeping because they are not able to enforce the bedtime rules. They're anxious for various reasons or other social or psychological factors. So it's really important to identify these, and especially in the older children and the ones who demand a co-sleep, trying to work out what's happening with them emotionally and behaviourally. And then looking at safety, is it still appropriate for their age? And are there safety measures in place? Just the next one, please. We always talk to and remind parents that when they're doing some behavioural sleep management, there can be an extinction burst. So this is where some of the unwanted behaviours will occur, again, after a number of weeks, and this occurs in a good percentage, and then will go away again. And so not to feel that the management has been unsuccessful or failed. I also wanted to talk briefly about medication because it's something that we often resort to or ask questions about. Melatonin in particular, we use a lot, or there are requests even from parents to use melatonin. So we know that the body naturally uses melatonin. It helps to regulate our circadian rhythm. That's thought to have a phase-setting effect. It's mostly effective in disorders caused by circadian factors like a sleep phase disorder in a child or blind children. With children and I guess with adults, the dosing is not clear and the side effects are also unclear. So there is still a lot of caution around using it. There's a study there that showed between 10 and 20, so 2 and 10 milligrams led to some improvement in sleep. So there's a big range. It's not on the PBS for children, and I've just put there what I tend to use. So just a circadian, which is a longer acting 2 milligram tablet, or compounded, and I often give it as a 3 milligram per mil and start with 2 milligrams. So normally my spiel to the parents is that normally it works well, that we're using it just as a period to help reset the sleep cycle, and it's not actually a sleep medication, and it needs to be matched with the other sleep strategies and shouldn't be used alone. And that also that we don't know the side effects, in particular the long term. Short term, there don't seem to be a lot of side effects. Some children don't like it or have a little bit of a hangover effect. And normally present it to use it as a trial, and it can work well in combination with other sleep factors. Just the next slide. So just touch on some of the other medications that we tend to use, and probably more so as paediatricians. Clonidine is widely used. The antihistamines, so the parents will often want to use some Valergan or some Phenergan. We really discourage it, but occasionally we use it just to break a cycle of a bad sleep pattern, and it should definitely not be used under 2, just by their medication regulations. And then definitely don't use benzodiazepines in children. Chloral hydrate and atypical antipsychotics are sometimes used in children with neurodevelopmental conditions, and we quite often use them. So this is our case. So just the next one, please. So our answer is, what is our diagnosis? We suspect it's probably a circadian rhythm disorder. And so what advice? Have a think. So it would be that we should put the child to bed when she's tired. So let her go to sleep later, and then gradually bring her sleep time earlier by 15 minutes each night until she's sleeping at a time that is more suitable. If we have time, I'll just quickly go through a bit about obstructive sleep apnea, because that's something else that's commonly seen. So this is just a second case. So a 5-year-old boy. He's been snoring for 2 years and worse over the last 6 months. He's a restless sleeper and he's waking tired. He's tired at school and his prep teacher's worried about his concentration and learning. He's grumpy, poor appetite and weight gain. So you'll probably see a lot of children like this. So next, what is the approach to this? And then what is our diagnosis? So disordered sleep breathing is very common, and there's a big spectrum from just from snoring to obstructive sleep apnea. So for this boy, we want a good history and examination. So I won't go through it all, but we want a history whether it is snoring or heavy breathing. Are there pauses? Is he mouth breathing? Is he restless and sweating? Does he have daytime symptoms? And then examination, again, looks broadly. When you've got severe obstructive apnea, you get this adenoid facies like the boy in the picture. You might want to do an assessment of airway or tonsil size, looking for nasal hypertrophy or polyps, looking for chest wall abnormalities and other growth abnormalities. This is just an example of some very large tonsils. So this is probably a grade 4. So going through the next one. And this is a helpful questionnaire which is often used in the medical ENT clinic at the Children's Hospital, I think developed by them. It's just a quality of life obstructive sleep apnea questionnaire, which can give you a bit of a comparison as to how children are progressing and gives you a bit of a guide of the questions to ask as well. So obstructive sleep apnea, is it a big problem? Yes, it's 1 to 5% in the paediatric population. That's based on Australian data. Males are equal to females. It can be difficult to diagnose clinically because a lot of children snore, but only a small proportion have obstructive sleep apnea. But even mild to moderate obstructive sleep apnea can result in quite significant problems. What is the treatment? So adenotonsillectomy is the most effective treatment. There are other treatment measures that can be trialled, and so a nasal steroid spray for 6 weeks can also be helpful in a mild to moderate obstructive sleep apnea, and sometimes the respiratory physicians may recommend some CPAP, some nasal CPAP. Should we do an overnight oximetry or sleep study? So sometimes these actually can be quite helpful. So an overnight oximetry, if it's positive and shows significant episodes of desaturation, can help guide an earlier ENT review. And a sleep study, while this can be challenging to get in Melbourne, and I can chat about ways to get this, can also help guide sort of the urgency of assessment. And more complex cases need to be referred to ear, nose and throat surgeon. The causes, mostly adenotonsillar hypertrophy. This is just a slide to remind you it's important to think about other conditions, so other syndromes such as Down syndrome and disorders of muscle tone, where you might see this much more often. Just an overview of what a sleep study may look like. This is just the sleep hypnogram in a 7-year-old boy, again highlighting the differences in types of sleep throughout the night. And the yellow here is that this boy is actually having seizures. Our sleep study will look at a lot of factors, but I won't go through that today. And so our case, what's our diagnosis? So this boy had obstructive sleep apnea, and what should we do about it? So for him, probably overnight oximetry, be hard to get a sleep study, and in the interim a nasal spray. So and then an ENT referral. So in Melbourne, to get a sleep study, mostly for the children's, it'll be through a respiratory physician. You can get it through Monash, and there are a number of private places where you can get a paediatric sleep study as well. So just a couple of questions just to finish. So you're evaluating a 6-month-old child. His mum is concerned because he's not able to fall asleep unless he's held. She's worried he won't develop normal sleep habits, and which interventions would be most effective. So have a think of this. So co-sleep with him, eliminate his daytime naps, feed him just before bedtime, leave a radio in his room or place him in his crib while he's still awake. So you can put it in the chat if you want, or just have a think about it. The answer will come following. Should be the next slide. So that's an easy one. So putting him in his sleep while he's still awake. So the second question, I'm seeing a 3-year-old child. His mother's afraid that he might have a mental health problem because he wakes up frequently at night. And when he wakes, he seems confused and incoherent and unresponsive to her voice. And then he's normal in the morning and doesn't remember the events. And you suspect he's got sleep terrors. So what would we do in this situation? Or what are you most likely to tell the mother? So children who have sleep terrors often experience them well into adolescence. Nightly diazepam is the treatment of choice. Sleep terrors are more common in children who have psychiatric illness. They occur in the last half of the night during REM sleep, or they're likely to be benign and pose no danger. So again, I think about what that might be, and then we'll show the answer at the end. So easy there. That's it. So any questions, feel free to put them on the chat. We covered a lot there.
Thank you, Rachel. That was fantastic. Very interesting and informative talk with lots of useful advice to give to parents, and also some evidence-based data that we can look at too, and a great quiz at the end to test our knowledge. Has anybody got any questions? I've just got one for you, Rachel. You mentioned previously about co-sleeping. I think that's what you called it, co-sleeping. You said that there were safety measures that parents could put in place to protect, to make sure, that the child didn't get accidentally squashed or whatever. What sort of measures are those?
So actually in that, I can talk about that as a separate. So yes, in our society, just on top of my head, it needs to be a firmer surface, no pillows or doonas, away from walls so the baby can't fall and be squashed down the side. Non-smoking parents, for example. That slide is actually referring to the opposite. So when older children are sleeping in bed with their parents, whether there are risks to them from the adult they're sleeping with. And so whether that needs to be considered from that point of view as well.
Yeah. Just secondly, with people using a lot more digital devices, in particular for this presentation, children, is there evidence that we're seeing more of a problem with sleep problems with children because of that? Is there any evidence that supports that?
Do you want to answer that, Kathy? So I'd say yes, there is. I don't have any of the data in front of me, but I think there have been some studies which definitely support that there's a lot more sleep challenges associated with the increased screen time and technology use. And I definitely see that in everyday practice. It's the constant battle of trying to get kids off technology and get a better sleep cycle, sleep schedule. So it affects their circadian rhythm because they affects their own natural melatonin production. It affects their sleep going to bed because they stay up late on screens. They want to chat to.
I think Rachel's just frozen. Yeah. All right. So thank you, everybody. Anybody got any last questions?
Can I just say, Catherine, that thank you for coming along, but there's some your health pathways have got some fantastic resources. They're really good in this area. So I think
they are. Yeah. Thanks, Kathy. Definitely. Yeah, if anyone hasn't used Health Pathways, I suggest you contact the PHN to get a password. It is absolutely fantastic. And in particular, our COVID Health Pathways has also recently been very much praised as well. So I really recommend it. So thank you.
Yeah, can I just also let people know, especially in the Wyndham area out here. So I don't know if our paediatric unit will be 2 years old next week. And we're actually, we will have 9 registrars in the unit from next week with one always in ED from 2 o'clock till 10 o'clock at night. So we'll be having a presence in ED, trying to improve care and looking after kids in the emergency department. So we will get our own emergency department one day, but that's going to be a build away. So so thank you.
Right. Thank you very much, Rachel and Kathy, and thank you everybody who's attended for coming along tonight. After this session, you will receive an email. It'll have an evaluation survey within that email, or if you like, the evaluation survey has just been put on the chat. If you'd like to fill that in beforehand, we'd be very grateful. And have a look on our website. We mentioned some other presentations at the beginning, so have a look on our website to remind yourselves of those, and book in for another event. And thank you all for attending.